Luigi, who I've got to know over the last 5 years and has become a friend, really, has a lot of the same interests and themes in terms of how they practice in St. Thomas's and so on. And we often have some good discussions about how you should ventilate patients. So he's going to take my concepts a bit further and show you perhaps what we need to be thinking about next.
Well, thank you very much, Tim. Thank you very much, all of you. Can you hear me okay? Okay, so it's after lunch. Now, lights are going to go a little bit low, so bear with me. So what I'm going to do in the next half an hour, I'm going to talk about three things, really. One is defining severe respiratory failure. Then I'm going to go a little bit more in detail about what we think is lung protective ventilation. And obviously, Tim has spoken a lot about the 6 mL per kilo as a lung protective ventilation. But I'm going to argue with you the concept of why we should go beyond that 6 mL per kilo. And then we talk about some ventilation strategy for severe ARDS. So may I start with just saying what I think are 4 truths of mechanical ventilation. The first one is severity is the primary indicator to individualized treatment, so severity. Homogeneous lung is a protected lung, so the aim of ventilation, there is only one aim, which is to increase lung homogeneity. And the more severe the lung disease is, the more uncertain we are that we are providing lung protective ventilation, regardless of the settings. And I'll show you some examples about that. And my fourth, what I call it truth, but I put inverted comma because it might not be truth for everybody, but this is what I think is important points, is that lung injury is not always ventilator-induced, but is ventilation-induced. So I'm going to talk a little bit about the potential dangers of spontaneous ventilation in severe ARDS. So the first thing to say is about severity. Obviously, this study has been presented before. We know from this recent 3 years old now, definition about what the criteria for ARDS are, but also we look at this oxygenation. So we know that we are looking at mild, moderate, and severe, depending on the PF ratio cutoff. And here I put that in kilopascal because this is what we do day to day. Less than 13.3 is severe. Yes, but here says severe with a PEEP greater than 5 or equal to 5. The thing is, sometimes we might have a different idea how severe the lung is if we obtain a PF ratio at different level of PEEP. Now, let me show you this recent study. This was just a few months ago published. And this is if we look patients with ARDS with mild disease. So these are mild disease based on clinical PEEP. So the clinical PEEP in this case was whatever the clinician had chosen to be. And you can see here, these are all 52 of mild, but when we go to 5 centimeters of water of PEEP, some of this mild clearly become moderate and some of them become severe. What it means that we are misjudging the severity of these patients, what they really are, if we apply a clinical PEEP. And sometimes having these measurements of 5 of PEEP will allow to standardize the ventilator and also to compare patient to patient and will give us a better idea how severe the lung is. And what goes into the severity is lung volume. And I'm going to show you some ideas how severity correlates with available lung volume. And you can see again there, when you do a 5 centimeters of water, the amount of recruitable lung increases, as it should be, and obviously that was masked at when it was a clinical PEEP. But also you can see here the number of patients when you go from clinical PEEP to 5 and 15 changes. So more patients become moderate and more patients become severe. Okay. So next one is that. So clearly when we stratify patient 5 centimeters of PEEP, then the total lung weight goes up from mild, moderate, and severe. The non-aerated lung goes up, so more dense, the lung. And then here, the potential for lung recruitment goes up. So you can see there are 5 centimeters of water. You have a good separation of different classes of severity of lung disease. And when you look at more histological data, that's the same thing. This is the diffuse alveolar damage increases with the severity and again with the severity of lung disease. And the same thing is the lung water. So if you have mild, moderate, and severe, the extravascular lung water goes up. But this is not surprising. This is also very interesting. So we looked at the importance of standardized severity with PEEP of 5. Now, this is another way, an interesting study, when you look at the relationship between physiological shunt, as shown by CT scan, and the log transform PF ratio. Just forget about the log transform, just think about PF ratio. But the key is here, FiO2 This is pure shunt fraction. This is not VQ mismatch. By doing 100% oxygen, we've abolished the VQ mismatch. And here they've created a very useful table where you can look at your left-hand side, your PF ratio. This is the shunt predicted by CT scan, and this is what they think will correspond. So a severe patient will have a shunt between 36 and 66%. And this goes very well with the data from the physiological cohort of the Berlin definition. And this is severe. This is refractory to 100% oxygen. This oxygenation cannot be reversed with oxygenation alone. So the question is, okay, PEEP of 5, 100% FiO2, moderate, severe, does it matter? Is it just an academic point I'm trying to make here? And what I'd like to say is that 1 in 3 patients will have already severe ARDS at presentation. Very few patients go from moderate to mild to severe. So these are the type of patients, when you see them severe, the majority of these patients, you will see them severe from the beginning. This is your day 1, day 2 in the ICU. And some of these patients will have very high shunt fraction. We said 40% on average, which will go very well with the other physiological study, and the mortality is very high. And this is not just the cohort. You can see here a variety of international study. They come with the same conclusion. That's roughly, for severe ARDS, that's roughly the mortality rate. So do you agree that this is a good recipe? Protective lung, low tidal volume, plateau pressure less than 28-30, minimizing driving pressure. Do you agree with that? Would you disagree with that? People disagree with that. You think is... Do you agree? Okay, okay. Now, I'm going to show you how this is just a starting point. And you're very familiar with this curve. This is a curve that was published now many years ago from the ARDS-net, showing that if the plateau pressure decreases, the mortality decreases. Okay? And when you give low tidal volume versus high tidal volume, the mortality in the higher tidal volume is higher. But I would like to show you this. The confidence interval are only positive or significant for the highest quartile of plateau pressure. And here goes from 80 down to 20. Okay, keep that in mind 1 second. And then obviously Tim has shown you this study, which I think is a very interesting study. This is the study where patients are ventilated with 6 mils per kilo of ideal body weight, protective, less than 28 to 30 plateau pressure, protective, and yet 2/3 of the patients, 1/3 of the patient were not protected. So this is on your left-hand side, you can see end of inspiration and end of expiration. You can see blue means normal lung, and green means collapsed lung. So this is protected. On the right-hand side, you see lots of purple. Purple is over distended lung. This is lung over time will create damage and long-term effects. But they're all ventilated with 6 mils per kilo of ideal body weight and 28 or 30 plateau pressure. So what's the difference? The difference is this. Look, this is a CT image, 3D CT image of 3 different patients. These are some of our patients. This has got severe ARDS. This is moderate ARDS. This is mild ARDS. Now, let's pretend these patients have the same height and the same gender. So they have the same ideal body weight, 420 milliliters in this case. We're going to give 420 mils into 180 mils. So this is the lung volume of this patient. It's less than a can of Coke. So that lung is now stretched 26%. And if you've got a mild patient with 3.6 liters volume, that lung now is stretched 11%. So you consider the same thing for severe ARDS, 6 mils per kilo, which is a good rule to start with, might not apply in patients with moderate or severe ARDS. So we've talked about how low tidal volume does not equate lung protective ventilation, because what we don't know is the end expiratory lung volume. And we've seen that that varies from 280 mils to 3.6 liters. Is it clear, that point? The question is, what about plateau pressure? So is it 28 okay? Is it 30 okay? Is it 20 what we need? And the whole point is transpulmonary pressure. The slide that you can see very clearly over there, it shows that there is no correlation whatsoever between airway pressure and the transpulmonary pressure, which is basically the lung distending pressure. So this is what the lung sees. And trust me when I say that if we apply 30 centimeters of water or plateau pressure to different people, some of them will be distended with a transpulmonary pressure of 8 centimeters of water, others 28 centimeters of water. So which one do you think would be protected? How do you know from the ventilator settings? There's no way of knowing, because what you're missing is the component of the chest wall, intra-abdominal pressure, and what you're missing is the lung volume. You have a guess with a CT scan, but the CT scan is not a very good images. Aha, so this, thank you very much. So here you can see 30 centimeters of water plateau pressure, but the lung sees 28 with this patient here. So this is above total lung capacity. So this is very over-distended lung. But then the other one sees only 8. In this patient might need some more. The oxygenation might needing a little bit more recruitment. We'll have some grace time for... Okay, so this is something that Louis Blanc has shown you before, which is great. This is a study to show that driving pressure is the key determinant of mortality and lung injury, not so much the tidal volume and not so much the plateau pressure. Let me go through once again with this one. So these are patients who are standardized here, same PEEP, but different plateau pressure. And consequently, the driving pressure increases, mortality increases. Now here you've got a patient with the same driving pressure and increasing PEEP. Therefore, the plateau pressure increases, mortality remains the same. But when you increase the PEEP, and as a consequence, the plateau pressure remains the same, so you manage to recruit the patient and the delta pressure decreases, these are the patients where the mortality decreases. So just let's look at this in a slightly different way. Oops, sorry. Previous one. Here you've got the plateau pressure, and here when you normalize for the same plateau pressure, you go with lower and lower tidal volume, you would expect here the mortality to be lower than here, yes? But no, it's the same. But look at this one. Here, when you have the same plateau pressure, but this time you normalize for driving pressure, which is basically what it shows is the tidal volume normalized for the size of the volume, then as the driving pressure goes down, the relative risk of death goes down as well. Right, okay, so we are saying that if we apply a pressure of 30 or less than 30 and a tidal volume of 7 or less than 7, patients who are split into medians, so patients who have median of plateau above 30 and below 30, no difference in mortality. Tidal volume greater than 7, below 7, no change in mortality. The only mortality difference is when, to achieve 6 mils per kilo of ideal body weight, you need to give an excessive driving pressure. That's where the mortality split. And you can see on your left-hand side there, as the driving pressure goes up, and by driving pressure, read the tidal volume normalized for lung volume goes up. Okay, so... And these are our own data, which basically shows that patients who have low recruitability, they get referred to us already on very high driving pressure. And you can see that when the recruitability is high, you'll be able to go up on the PEEP because your driving pressure, despite being high, you still control for the plateau pressure. Now, so the first thing is severity. We've looked at severity. Now, the second and third point I want to make is about lung homogeneity. Now, you will agree with me that that's a very heterogeneous lung. So there is a lung that is quite consolidated. Some of them in purple is over distended. But what is important is the heterogeneity depends, well, is proportional to the lung severity. Mild disease is homogeneous, tends to be. You can see over there on the left-hand side. More severe lung disease, they're more heterogeneous. So the higher the tidal volume here, even if they are considered protective, the higher the damage is going to be. Okay, now my fourth point is the ventilation, or is it ventilator-induced lung injury or ventilation-induced lung injury? I'd like you to think about some iceberg analogy. So when you set the plateau pressure, what you're setting is only what you can see, the pressure that you can see above the water. What you don't see is what the pressure that the patient generates, i.e. the pleural pressure. But the lung, unfortunately, sees the whole of it, which is the transpulmonary pressure. And that's why when the patient is spontaneously breathing, this is the airway pressure, you see no difference between these two airways, but this is the esophageal pressure. So this is the negative pressure the patient is generating in order to trigger the vent. And you can see that there is a big difference between these two breaths. And when we look at this particular one here. Now, follow me 1 second. Look, this is flow at the top, this is volume, and this is pressure. So when you set your plateau pressure, would you agree that these breaths have all the same plateau pressure? Roughly, give or take 1 centimeter of water. And here, the patient is not breathing all the time. So here is no breathing, no esophageal, here is breathing. Now, look at this. This is a transpulmonary pressure of 20, so this is all what the ventilator is delivering. But here now, the patient is taking some breaths, so you are adding this negative to the positive. Now the transpulmonary pressure is 37. So now you have protective, injurious. Protective, injurious. And this is a very important concept. There will be a talk later on about asynchronies. And this is what we do in clinical practice. This is a screenshot from one of the Philips ventilators that we have in our unit. And this is esophageal pressure there with the airway pressure over there. This is in mandatory ventilation. You can see the swing is actually quite small. But here it starts breathing now. This is negative pressure from spontaneous ventilation, but look now at the swings. This goes from 15 to -5, and this is millimeter of mercury. So multiply by 1.36, and you see the massive transpulmonary pressure that this patient can generate. This is a video just to show exactly the same thing. So the patient breathes in, and the chest goes up, and you can see the massive swings. So even if this patient is on 5 or CPAP support, it's not really protected because you've got massive, what you do not see is the transpulmonary pressure generated. So I think what I'm going to conclude about this part is that in severe ARDS, it's difficult to be sure about lung protective ventilation. We need to apply long tidal volume, low tidal volume. This is important, but it's only the beginning. And how low that goes depends on the lung volume. Plateau less than 28 is important, but that depends on chest wall elastance. And then think about driving pressure a little bit more. But in spontaneously breathing patients, it's very difficult to quantify precisely. And when we think about homogeneity, we're thinking about two mechanisms. We have only two mechanisms to homogenize the lung. One is PEEP, or mean airway pressure, depending on what modality of ventilation you're on. And the second one is prone position. There is nothing else that will homogenize the lung. So can I go through a case? So we've got a 23-year-old lady, 3 days, unwell for 3 days, deteriorating respiratory failure, intubated, but rapidly deteriorating. This is the setting of the ventilator. What do you think? Acceptable, non-acceptable, appropriate for the level of FiO2? I would say so. I mean, it's not particularly elevated. PEEP seems to be appropriate for the FiO2. This is a chest X-ray. You can see at the beginning when she presented, she's still non-intubated, and this is 24 hours later. So the question is, what do we do now? What would be your next step? Prone. Okay, that's great. The only problem is to wait because it's a little bit later in my presentation. But I agree. So this is what we've got available. We're talking about severe ARDS. We've done the conservative fluid management. We've done the tidal volume. She's already on high PEEP. She's not breathing. So this is what we've got. We've got to consider prone position. Got to consider APRV, neuromuscular blockade, or some extracorporeal support. So the first thing we want to know is this lung disease very severe? So first step, PEEP 500%, even if it's for 5 minutes. And then the second thing, would you agree that it's looking at the hemodynamics very important? So what we do, we look at echocardiogram, that's on the left-hand side, why we do it. But you can see here that this is one of the major problems in severe ARDS, which is right heart failure. Very dilated right heart, and this is a major problem because it's common. It's about 1 in 5 patients across the ARDS population will have it, and it just effectively doubles your mortality. So once we've done that, neuromuscular blockade, if we have not done it, is important. This study has already been presented, but I'd like to stress the idea that if we paralyze a patient for the first 72 hours, we only need 10 patients to save 1 additional life. So this is an incredibly low number needed to treat. And this is how they do it for 72 hours. They do it with cisatracurium, but I don't know how many people use cisatracurium. You don't have to. This meta-analysis shows that it doesn't matter which one you use, you're always going to favor neuromuscular blockade if you then paralyze the patient for a few days. Now, why is that? Look at this. Do you remember I was talking about lung descending pressure and spontaneously ventilating? So this is flow, this is pressure. This is flow, this is pressure, and this is the esophageal swings. So high swings means a lot of intrathoracic pressure being generated, more injurious. This is the neuromuscular blockade, it goes here, and over time the swing reduces. So you can see how for the same plateau pressure, the effective transpulmonary pressure decreases. And that's one of the mechanisms by which neuromuscular blockade can be effective. Now, recruitment, I'm going to go very fast on that because it's been discussed. Essentially what we want is recruit alveoli. We want to distinguish between the patient who recruits, and the patient who doesn't recruit. And obviously this will lead to very different strategies. The way we do it, there are 3 possible ways. Sustained inflation. You've seen a lot of incremental PEEP or high pressure controlled. Why do you think this is the most common one? Because it only takes 40 seconds. It's very easy to do at the bedside. This is quite long. People who have done this, they realize they need to be at the bedside for quite a long time. So it's less favored, 23% in this particular study, but actually much more effective. And I'm going to go a little bit fast here to say that you go up on the PEEP, maintaining the same driving pressure, and you go down to find out the optimal PEEP. How high can you go? Depends how brave you feel, what's your patient like. But in the published literature, it's either 45 or 60. And there are other ways of doing it. For people who said 60, I'll show you something. So here you can go up a little bit with the same driving pressure until you get 45, and then measure compliance here and compliance there. So go up and down again. And if this compliance is improved, means you're recruiting. Go up again and come back to baseline. Compliance here, if it's better than this, you're still recruiting and go up. But if you see there is a change in compliance and goes down, there's no point in going up anymore. You've recruited all recruitable. What you're doing now is just over distending. And I'm going to skip this one for sake of time and I'm just going to talk about prone position. You all know why we do prone position, and Tim has already explained it really well, the mechanisms, but I'm just going to say these are the mechanisms, these are the criteria that we used in the PROSEVA trial, and with this criteria, patients were randomized into proning or non-proning. So this is a good starting point. But I'm just going to say that sometimes the CT imaging can make us think that someone is likely to respond to proning better than someone else. And what this study shows that no matter what your pattern of injury is, you cannot predict the response to prone position. So when in doubt, with that severe, moderate to severe ARDS, prone. Do not get confused or discouraged by the CT appearance. Okay, so, and that clearly there is a big difference in mortality that goes beyond the 28 days, goes beyond the 90 days mortality. Okay, so the question is why prone position is not very new. So that's been going on for many, many years. The question is why today? Why in 2013 we are showing a 16% absolute reduction in mortality and not 10 years ago or 20 years ago? And the reality is this, that we are getting better, or at least generally we're getting better at providing low tidal volume ventilation. We are doing it in the more severe or moderate ARDS for a longer period of time. So if we do it with these three conditions, the mortality associated with prone position is much more favorable. So 2/3 of the patients improve, especially if you can co-deliver it with low lung protective ventilation. And here your number needed to treat is 11, again, very low. It's also very satisfying. You can see this is a patient has not responded to recruitment, 100% oxygen, APRV, and what he needed is prone position. This is a very high sort of gentleman not really responding to normal recruitment. Okay, so PEEP optimization. I'm just going to say something that despite the fact that the trials have not shown an improvement in mortality, we know what they improve is actually the need for rescue treatment, which is very important. And how have I got some extra bonus time, or shall I skip through? Okay. And the importance of the PEEP is so much that even in this is a scoring system for response to ECMO, the way patients have been ventilated pre-ECMO is an important factor to give mortality, so for a mortality outcome. So the lower the PEEP, the higher the mortality post-ECMO. So this is quite important. There are different ways of doing it. We've seen the compliance curve. This is going up and this is coming down on the PEEP. We can choose the PEEP with the best compliance. We can do it using EIT, or we can do it using the esophageal manometry, which Louis Blanc has shown before, earlier on. And this has been shown that if we target transpulmonary pressure rather than plateau pressure, we can reduce the number of patients who fail conventional ventilation. And or you can do it more simply looking at PF to PEEP table. Or you can take a more simplistic approach and just use a 5 to 10 for mild, 10 to 15 for moderate, or 15 to 20 for severe, depending on what you've got available and at what time of the day it is. So when we get to PEEP optimization, clearly we have the last bit, which is open lung strategy. We've got two ways, really. One is the HFOV, but we've seen that the two studies, the Canadian and UK, have practically have made HFOV fall apart and is not used anymore. And the other one we've got is APRV, which will be a talk later on, so I'm not going to talk a little bit more in detail about that. So when everything fails, it's quite clear that extracorporeal support is required. And just this one is the last slide to show that when you think about what really makes a difference is low tidal volume, perhaps PEEP, and certainly prone position and neuromuscular blockade. And this is just a way to say that these are my conclusions. So I would suggest define disease severity. Just do it in standardized fashion. Might not be possible all the time because some patients are very severe, but this is the best way. Attention to fluid balance after shock resolution. Use the lowest VT for a plateau of 28 to 30, but But think about intra-abdominal pressure and esophageal pressure. Prone position is definitely your friend. And be aware of inspiratory synchronization mode during spontaneous breathing, because that will increase the unseen portion of lung stress. And I'll thank you for your attention.